Regardless of the health profession you practice, medicine, nursing, physiotherapy, or paramedicine for instance, being a novice is challenging. Set free from university, graduates are armed with a mind full of fresh knowledge and skills, inextinguishable excitement, and the strong desire to provide outstanding patient care. However, at times, despite being in the game as a graduate, it may feel as if you are playing by an entirely different set of rules. Let me elaborate. Taken from my experience on placement as a final year student, I have often witnessed my mentor waltz into a patient's house and seemingly pluck a diagnosis out of thin air. Meanwhile, I'm there trying to complete a thorough assessment and ask all the right questions, sifting through my findings to cautiously determine the most pertinent factors in differentiating a specific diagnosis. With the shift of ambulance education to the tertiary setting, the novice paramedic's level of clinical and theoretical knowledge has undeniably increased. However, the ability to implement this knowledge efficiently and appropriately is restricted by their ability to make fast and accurate decisions. For health professionals in particular, decision-making is often associated with a degree of uncertainty. In the field of paramedicine, this risk is amplified by a variety of factors including stress, fatigue, uncontrolled environments, lack of resources, and incomplete patient histories. Furthermore, patient conditions encountered are often high acuity and time-sensitive in nature. As such, high-density decision-making, with a large number of decisions required within a limited time frame, is a key factor in paramedic practice. This naturally increases the risk of provider error and adverse events. Clinical decision-making revolves around a paramedic's ability to gather, evaluate, and synthesize clinical information in a timely and efficient manner. In combination with clinical decisions regarding assessment, diagnosis, and intervention, paramedics must also make logistical, operational, and resource management decisions on a case-by-case basis. Closely linked with clinical decision-making, clinical reasoning is a crucial element of paramedic competency, relying upon clinical skills, communication, and reflection on practice. It is a combination of knowledge, critical thinking, judgment, and problem-solving to discern a particular diagnosis. As poor clinical decision-making and reasoning can lead to clinical errors and adverse events that may compromise patient safety, it is imperative that the clinician strives to optimize their reasoning and decision-making skills. The evolving models of contemporary paramedic practice, from what was once a largely protocol-driven vocation with limited clinical autonomy and responsibility, has seen an increase in scopes of practice, demanding higher levels of clinical judgment, decision-making, and professional accountability. Despite the use of clinical guidelines and protocols, the management of a patient still requires a certain degree of judgment from a healthcare professional. As the demographics of paramedic service recipients change, together with a recent focus on models of care aimed at alternate healthcare destinations for perceived low acuity patients, clinical reasoning and decision-making skills have become invaluable. Although widely established in other healthcare disciplines, minimal research has been conducted for clinical decision-making within the paramedic arena. As such, extrapolating the current theories and frameworks of clinical decision-making and reasoning from other disciplines is necessary in order to optimize patient outcomes. If I were to ask a person on the street what the role of a paramedic entails, I would most likely hear a response such as saving people's lives, or an answer alluding to the adrenaline-packed, fast-paced side of the job. You simply won't hear about the nanas who've taken a fall, let alone any degree of insight that fathoms the multiple decisions a paramedic must weigh up for each patient. As such, it is easy to see how both clinical reasoning and decision-making are aspects of the job that are essentially overlooked. In reality, it is almost overwhelming to comprehend the sheer volume of decisions a paramedic must make per case. And it's not until you reflect on a particular job that you truly realize how heavily your decisions, clinical or non-clinical, impact upon patient care. Understanding the concepts of clinical decision-making and clinical reasoning plays an imperative role in my education and transition to paramedic practice. From in-class theory lessons to clinical placements, I've been able to develop my skills in responding to and managing an emergency in a systematic fashion. This has resulted from a combination of observation, repetition, reflection, and following the actions of my preceptors. At university, we are told to know and carefully follow clinical practice guidelines and protocols. we are schooled in the swift recognition of potentially emergent conditions and the necessary treatment to address pertinent signs and symptoms. In reality, a patient's clinical features may fit the criteria of multiple conditions, thus making determining a diagnosis and constructing a treatment regime complex. Despite being introduced to the importance of sound clinical reasoning to make justified, safe decisions, it is essentially difficult to develop these skills in a simulated environment. Furthermore, it remains challenging to comprehend and learn how decisions are in fact made. As such, value would be added if scenarios undertaken at university focused on reasoning strategies in addition to clinical aspects of care. Being out on road as a student paramedic aids to improve my clinical decision-making skills and forces me to examine my own decision-making process. These experiences also encourage me to be cognizant of the personal and cultural attitudes, values, and beliefs I may hold when making decisions. I'm aware that as my clinical knowledge and experience grows, so will my ability to make timely and appropriate decisions in favour of the patient's best interest. That is, to discern what skills are required, in what order, and to what degree. By investigating the theories behind clinical reasoning, I am able to comprehend how these play a role in paramedic decision-making and practice. In order to minimise the near misses or adverse events that occur in the pre-hospital setting due to weak paramedic judgment and decision-making abilities, it is vital to analyse how these decisions are in fact made. Clinical reasoning represents a multidimensional and complex thinking process. Both inductive and deductive reasoning may be utilised in clinical decision-making. Inductive reasoning involves drawing conclusions from facts and using logic, whilst deductive reasoning involves forming a hypothesis and proving it with evidence. Developed by Evans in 2008, the chief theory which explains how health professionals approach clinical reasoning and decision-making is the dual process theory. This process proposes that an individual uses one of two cognitive processing systems to make a decision. System 1, also referred to as intuitive or experiential reasoning, is rapid and subconscious. It utilizes heuristics and shortcuts to arrive at a decision, doing so with minimal effort and greater cognitive efficiency. As a non-analytic thinking strategy, it is seen by some critics as subjective and prone to error, as it relies on pattern recognition and a clinician's past experience. System 2, frequently referred to as rational thinking, is deliberate and conscious. As an analytic process, System 2 thinking consists of cognitive elements such as logic and represents clinical reasoning that is purposeful and reflective in making a decision. A more experienced paramedic can recognize a pattern by using the fast, intuitive pathway, yet must be wary of jumping to conclusions, whereas a novice proceeds down the slower, more analytical pathway to arrive at the same conclusion. For instance, when confronted with the same clinical problem of flank pain, two different clinicians may approach a situation in very different manners. One paramedic may match the patient's presentation to a particular illness script acquired from past cases, and thus immediately assign a working diagnosis of renal colic. Another paramedic may utilize more rational thinking and consider alternate diagnoses, such as a urinary tract infection, before determining a diagnosis or treatment plan. In the early stages of research into clinical decision-making, two predominant methods were utilized to help students understand and reflect on their thought processes. The Think Aloud technique, where participants would voice their reasoning process throughout performing a scenario, and simulated recall, where participants would watch back videos of their performance. Both of these methods remain evident in the current tertiary education paramedic curriculum. Based on these review methods, 6 main clinical decision-making strategies were discerned and categorized into either System 1 or System 2. Event-driven, intuition, and pattern recognition are examples of System 1 thinking strategies, whereas exhaustive, hypothetico-deductive, algorithmic, and rule-out worst-case scenario are examples of System 2 thinking strategies. Whilst I will not expand on each of these individual thinking styles, it is important to acknowledge their existence and relevance. The dual process theory suggests that System 2 has a supervisory role over System 1. The ability to calibrate one's thinking refers to clinicians with critical thinking who are able to successfully utilize both systems appropriately and efficiently. Metacognition, the capacity to think about non-analytical and analytical processes at a higher level of cognitive reflection, functions to monitor clinical reasoning and ultimately to standardize clinical decision-making. In most instances, paramedics may be inclined to use one system more than the other. A study conducted by Jensen et al. In 2016 yielded results suggesting that both paramedic students and paramedics perceived they were able to use rational thinking more than experiential thinking. Despite uncertainty as to which thinking strategy is preferred for any particular clinical circumstance, it is important for all clinicians to be aware of their personal decision-making and be educated in the advantages and drawbacks of each strategy. As the paramedic profession evolves and matures, it is essential for patient outcomes to remain top priority. At the core of providing high-quality care is the ability to make timely decisions that are safe and effective. It is vital for paramedics to appreciate the power and value behind making decisions. As I look to begin my professional practice, I now realize the importance of understanding metacognition, appropriately utilizing the various decision-making strategies, as well as being aware of cognitive biases. Arming myself with knowledge is one thing. Clinical reasoning and decision-making are not solely analytical or reliant on recalling the facts, yet are rather multidimensional cognitive processes which reflect the integration of a clinician's experience with their individual personality and values. It is an area of paramedic practice that I will strive to build upon throughout my professional experiences to foster positive patient outcomes whilst maintaining integrity and accountability.